Hi everybody, it's Kate Wakelin here from Neuroendocrine Cancer Australia, and welcome to Facebook Friday for the first Friday for this broadcast, at least in 2021. So it is the 15th of January 2021, and welcome, Happy New Year, welcome to the new year for everybody joining us live in our Facebook private discussion group, and also those who are catching up later via our YouTube channel. Just before I go any further, I would just like to pay my respects to the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to elders past, present and emerging. I often talk about one of the things I love about the land that I come to you from, but over Christmas I was very lucky to be able to visit the southwest coast, which is where my family are from, and so I didn't know the name of the indigenous lands that they live in and that we were visiting, so I did actually look that up, and it's the Gunditjmara country, and apologies because I probably have pronounced that appallingly, but I think it's always good for us to be thinking about where we are, and you know, if you ever know the name of your land, it would be really interesting to know that too, maybe in the comments. I can see that a couple of people have joined me, which is really fantastic. So I know the system works. I'm a little bit rusty over having had a couple of weeks off, so we'll see how this goes. Just before I go to our question that we're going to focus on this week, I did want to just briefly touch on the situation with COVID. If you're in Australia, you're very lucky. I know that things have been very concerning overseas over this last few weeks. And we think of our neighbours in the UK and in the USA and in many other countries where things are very dire. And I guess the good news in those countries and you know, forthcoming in Australia is about the vaccines, which the clinical trials have been incredibly fast and far more promising than we really hoped to did hope. So I know that they are vaccinating widely in some of those countries, and I guess in Australia that gives us a chance, as we look forward to having vaccinations in around a month's time. We get to look at the experiences of those other countries and learn from those experiences. And I know that the planning is very much underway. There's been a lot of questions about vaccinations and COVID for people with cancer, and particularly NETs. And I just wanted to reassure you that that's something we're actually working on, getting a guest expert into our Facebook Friday in one of the coming weeks to be able to really drill down. You know, there's some questions that I feel equipped to answer, but there's some questions where we know that it's really great to have an expert along to really give us the lowdown on these things. So we're looking forward to having that and having some more news about that soon. So the topic that we decided to really look at this week was related to a question that someone emailed me in. And I guess the thing about a question is that, you know, actually they started their question by really apologising and saying, oh, this is a really trivial question. It's probably a really silly one. And I'm always keen to stress to everybody that if you've got a question, probably other people are wondering about the same thing. There's no such thing as a silly question, and usually there's more than one person wondering it. If you're wondering it, you're probably in good company. So this person was really asking about the way that neuroendocrine tumours affect hormones, and I thought, well, it's a really fantastic question, and I could type her a response, but I thought actually probably there's lots of other people who have questions around the types of hormonal syndromes that can take place and can happen with NETs. So the first thing to say is, and I always say this, but everybody is different. So NETs are an incredibly diverse group of cancers, and so your neuroendocrine tumour won't be like, you know, the next person in the waiting room or the next person in the support group. and having like, so that every tumor is different, but every body is different. So you can have tumors that look really very similar under the microscope, but they behave really differently in different people. So the things that I say today will be just general, and I'm just having a little bit of trouble with my feed, so I'm hoping that it's still working, but maybe, hopefully, we'll just see. I'm going to persevere, and maybe if you're hearing me while I'm having some technical trouble, then you can just give me a little quick comment to make sure that we know that it's working. I've had some dodgy internet today. I think it must be all of the people on school holidays. So I'm going to persevere on, and hopefully I'll see a comment soon telling me that yes, you can still see it. So the other thing is, I'm going to be talking generally. If there are questions that this raises for you about your own situation, then please do talk with your doctor about it. Our support groups and our Facebook group are fantastic for sharing experiences and questions with each other. But for your own medical management, please do talk to your doctor. Great, you can still hear me. I can't see anything on my screen very much, but I'm just going to keep. I can see your comments, which is brilliant. So I'm going to power on through. So I think the place to start is really to think about where the tumors start, which is the neuroendocrine tissue in our body. Now, neuroendocrine tissue, it's a mouthful. It's part of our body that when it's working well, we don't even know it's working usually. But it's the parts of our body that are producing hormones. And I think when we think of hormones, often as lay people, we think of our sex hormones. So, whether it's estrogen or progesterone or testosterone, they're the sorts of hormones that people often think of. But actually, we've got cells in our body, throughout our body, right through from our brains to our bums, that produce the various hormones that our bodies need to tick over and work properly. So, and as I said, when this is working well, you don't even know about it. So whether it's your adrenal glands producing adrenaline, whether it's the serotonin producing cells producing serotonin, which helps squeeze the food through the gut and make sure that you digest the food well. Whether it's some of your digestive enzymes, so like the acids that are in your stomach. So there's lots of different hormones. Neuroendocrine cells are the special cells in your body that normally produce those hormones. And what happens with a neuroendocrine tumor is that you've had a mutation in the genetic material inside one of those cells, and that is meant that it thinks that it needs to make more of them and more of them and more of them, and then you get a lump, and that turns into that's a tumor. And part of that can break off and spread to other parts of the body, which is when we get metastases. So because neuroendocrine tumors grow from neuroendocrine tissue, and the job of neuroendocrine tissue is to produce hormones, sometimes the tumors continue to produce the same hormones of the cells that they grew from. The bigger the mutation in the cell, the less like a normal cell that tumor cell or that cancer cell will look. And because of that, low-grade tumors actually look, where it's not a very big mutation, low-grade tumors under the microscope, they look fairly similar to normal neuroendocrine tissue. And because of that, the lower-grade tumors are actually the ones that sort of still remember how to produce the hormone. So it's actually the lower grade tumors where we see a lot of people with hormonal syndromes. The higher the grade of a tumor, the less likely it is that you'll have tumors that are squirting out hormone into your body. So actually someone's just commented in the comments, and it's fantastic that, thank you for putting comments in, because it means that it's still working. Someone who has NEC, which is neuroendocrine carcinoma, which is it's grade 3B, so it's it's a high grade tumor. And the thing with high grade tumors is that they've had a big mutation from the original tissue, and usually the high grade tumors have lost the ability to produce hormones. So yeah, you're right. You're probably not going to see hormone syndromes in those high-grade tumours like NEC or grade 3 tumours. I'm just looking at my notes because I'm rusty and I don't want to forget things to tell you. The hormone that's produced by these tumours really relate to where the tumour originated. So, for example, if you've got a pheochromocytoma, which they occur in the adrenal glands, you're more likely to get a adrenaline producing tumour. If you get a tumour that's originated in the pancreas, you're more likely to get a tumour that is producing too much insulin or other hormones that the pancreas would normally produce. So it's specific to the type of tissue that tumour grew out of that will determine if you get a hormonal syndrome. So, and often this is called a functional or a non-functional, or a functioning or a non-functioning, or secretory or non-secretory tumour. And really frequently we talk about functional tumours as for people where there's carcinoid syndrome, and that's where you get the classic facial flushing, shortness of breath, diarrhea, and a variety of other symptoms. And that's usually because you've got too much serotonin that the tumour is squirting out into your system. It squirts too much. They squirt too much hormone out, but they forget when to do it, so they lose the ability to sort of read the room, and they tend to blurt out hormones when you don't need them. So, you know, diarrhea in the middle of the night, even if you haven't had anything to eat, that kind of thing. If you have a non-functioning tumour where you're not getting symptoms of hormones, it doesn't mean your tumour is not producing hormones. Sometimes we can still see the hormones in the test. So one of the tests that we use to monitor hormone production, particularly in serotonin producing tumours, is the 5-HIAA blood test. Sometimes people will have other blood tests like the plasmin metanephrines blood test for people with pheochromocytomas or paragangliomas. So there's other tests that we can use to monitor some of those hormone levels. But so sometimes often you get symptoms, but not always, and it doesn't necessarily mean that you have no extra hormones floating around your body. It just means you're not getting symptoms from it. Hormone levels might be fine on the blood test or the urine test and you're still getting symptoms, or alternatively you might have no symptoms but actually the levels look quite raised. So we used to think that there was quite a correlation there, but it seems that the water's a bit more murky than we used to think. And individual bodies respond to hormones in very different ways. So I just wanted to give you an example. There's actually lots of different types of lots of different hormones that are produced, and I have lost the page of the thing that I'm going to read to you. So that's fun. Bear with me for a second while I find it, because there's much more information about this. We've got two booklets, so one for patients and one for health professionals. The health professionals booklet is actually where there's a lot more detail about the types of hormones that can be produced. And I've lost the page. So that's my messy desk for you. My messy coming back from holidays. Oh, I wish I could find the page. Anyway, it's I will maybe post a link to the booklet and to the page. But look, here it is. So, for example, some of the pancreatic hormone syndromes you can get are when they produce too much insulin, which is called an insulinoma. These are really, really rare. So sometimes when people get these, they tell me that their doctor actually looked a little bit excited when they got their diagnosis, because it's a bit like finding a really rare mineral or a really sort of precious gem, because it's so unusual. Gastrinomas is where the pancreas produces too much gastrin, which is part of your digestive enzymes in your stomach. So people can actually, if they've got a gastrinoma, they might be more likely to get a stomach ulcer. There's also glucagonomas, which is another pancreatic hormone that's secreted that can raise your blood sugar. So it's just an example of some of the syndromes. So often we just think of carcinoid syndrome with the flushing and the diarrhea, but there's actually lots of different sorts depending on what sort of tumour you've got. You can actually get tumours in your reproductive organs as well, and sometimes people ask me, well, will a neuroendocrine tumour have a difference to my function of my ovaries or my testes or my prostate. Tumours in those organs are super, super, super rare, and we actually don't have a lot of information about the sorts of whether that increases the level of circulating hormones in your body. We think probably it's very, very unusual for that to happen, but if you have a tumour in your ovary or in your testes or your prostate or reproductive organs, then I guess it's a possibility that you might get an alteration in the hormone function of those organs. Something that's really important for me to say is that neuroendocrine tumours are different from other cancers in that they are not fed by hormones. So sometimes people worry, because we know in breast cancer and particularly in prostate cancer, those types of tumours often are actually fueled by the hormones that the body produces. So someone with breast cancer that's hormone receptor positive might go on hormone blockers to actually try and inhibit the growth of any tumour cells. And with prostate cancer, we know that often that's fueled by testosterone, and so the gentleman who's got prostate cancer might then go on hormone blockers to help inhibit the growth of that prostate cancer. So neuroendocrine tumours are not like that. So sometimes people ask me, can I go on HRT? And as I always talk with your doctor about your own personal risk, but we don't believe that there's any interaction or that hormone therapy like hormone replacement therapy make any difference to the growth of neuroendocrine tumours. So that's something to be reassured about. So with tumours, with neuroendocrine tumours, I guess the main stay, the gold standard, the first line of treatment is somatostatin analogues, and this is where you can get some other interactions with other hormones that your body is normally trying to produce. So somatostatin analogues are usually monthly injections, although you can get short-acting versions. And there's been a few conversations in our Facebook private discussion group about those really recently. There's actually another video on the different types of somatostatin analogues and how they're given. I might put a link to that in the notes. But basically, somatostatin analogues fit into special receptors on the surface of our neuroendocrine cells. They're called somatostatin receptors, unsurprisingly. So a lot of tumour cells have this, but our normal neuroendocrine cells have these receptors on their surface as well. And look, they're complex in the way that they work, but the way that I like to think about them is that it's a little bit like putting when you've got a PowerPoint and you've got a toddler who's interested in putting things into other things, you can get the plastic covers that go over the PowerPoint and they stop anything, powering that device. So I feel like sometimes a useful analogy about the somatostatin analogues is saying it's a bit like putting a PowerPoint protector. So it blocks up the receptor and stops the tumour from being able to fuel, but it also stops the tumour from being able to produce hormone, which reduces the symptoms of neuroendocrine tumours in heaps of people. So they're really useful drugs, both in terms of reducing symptoms and also reducing growth. The thing is that I just said before, our normal neuroendocrine cells also have these receptors. So sometimes these drugs will give us side effects because it inhibits our normal neuroendocrine cells in our body from doing their job. That they're just quietly going about their business, trying to treat you as a normal human being and give you your normal level of enzymes and hormones. But sometimes that can get a little bit mucked up because of these injections. It's a common side effect. So, I've talked quite a lot about fat malabsorption when we've talked about things like needing to take an enzyme supplement called Creon if you're not absorbing or digesting, breaking down, absorbing fat in your diet particularly well. We don't have a lot of information about other hormones that might be inhibited because of these injections, but a lot of people talk to me about things like dry skin or brittle hair, and we wonder whether that might be at play. A lot of women actually tell me that they feel like there's a change in their menstrual cycle or things go really awry when they're premenstrual and they're on these drugs. So again, it's not something that the drug companies have done a lot of measuring on. We don't have a lot of data on this, but anecdotally we feel that probably there is an impact on some of these other hormones that your body might produce. So someone's actually just asked about neuroendocrine tumours in the lungs, so that they can actually produce a number of different hormones, just like your pancreas. So you can get serotonin producing hormones, serotonin producing tumours in the lungs, which result in the carcinoid syndrome. There's another hormone called ATCH, which when you have too much of that being produced, you get a syndrome called Cushing's syndrome. So these are rare, but they can happen. And if you feel like that's something that's been referred to, about you, then, you can certainly get in touch with me for more information about those various syndromes. Someone's just asked a really good question, which is, can the hormones created by NETs affect other hormonal pills, such as contraception? I'm just thinking carefully about that. I don't think so. I've never heard of an interaction between the hormones created by NETs and having an interaction with other hormonal medications like the pill. Having said that, if you've got diarrhea because of terrible carcinoid syndrome, or actually if you've got diarrhea because of another treatment, like you've had a section of your bowel removed, you can reduce the absorption of some other medications, including the pill. So that would be the thing I would say. But not that we know of in terms of the hormones that the tumours produce interacting directly with other hormone treatments that we might have, like hormone therapy or like hormone replacement therapy for menopausal syndromes, or the pill. We don't have any evidence that I'm aware of. If I find anything out about that, I'll put it in the notes. But I'm pretty sure the answer to that question is they're fairly unrelated. Someone else has just said that, and this is a really good point, that they were pushed into early menopause because of radiation or chemo, and both of those treatments can have a really big impact on the normal hormone functioning. So with radiotherapy, we see changes for external beam radiotherapy, where you're sitting under a radiotherapy machine. If that machine is pointing at the organs of yours that produce those hormones, that will often shut that hormone production down. So if you're a woman or a man having pelvic radiotherapy with an external beam, that will often affect if you're a woman, your monthly cycles, and if you're a man, the production of testosterone. So that might be production of sperm, but also erectile function can be affected because of that. Chemotherapy actually also shuts down often the functioning of our glands, our sex hormone glands, like our ovaries and our testes and the prostate. So they can push you, if you're a woman, push you into early menopause. If you're a man, you can have infertility and erectile problems. That's to various extents can be reversible, particularly for men. But for women and men of childbearing age, if you're having external beam radiotherapy in the pelvic area, or if you're having chemotherapy, if they have time, and sometimes these treatments are very urgent. So, for some of these treatments, if it's a very fast-growing tumour, they're going to want you on treatment really quite quickly, often, the next day or in the next few days. But hopefully they will have discussed with you the options of freezing eggs, and potentially banking sperm. Good point from that person, that chemotherapy and radiotherapy can affect your hormone production. Having a menopause that's chemically induced is really different from going through a normal menopause. So often women, when they're going through a biological menopause, you'll get it's often a very slow process, so it can take around, even up to 10 years to go through that sort of gradual shutting down of the ovarian function. With a chemical menopause like that, that's induced from chemotherapy, that happens really fast, and so it can be really quite severe in terms of side effects. If you're having chemotherapy treatment for a neuroendocrine tumour that's putting you into that really abrupt menopause, and you're getting lots of symptoms because of that menopause, it's worth talking to your doctor about whether it's safe to go on hormone replacement therapy, just to help ease some of those symptoms. So I'm happy to talk with anyone over the phone about these things in more detail, but Yeah, that's absolutely true. I'm just going to have a little bit more of a look at the questions and see if there's any others that have come through. Um, there probably will be follow-up questions from this chat, and I'm really happy to come back to it in on a future week. But that's probably as much as I wanted to give you today, because it's quite complex and I don't want to really overload us. And as usual, I'm just looking at my clock and thinking, I have managed to rabbit on for a really long time, so I'm sorry about that. So just before I finish up today, there's just a little bit of news that I wanted to update you with the new year. The first thing is that we had some really fantastic news from our consumer advisory group. Some of you may know that we've got a consumer advisory group who meet regularly throughout the year and work with us on projects and research and really important things about the overall direction of our organisation. One of the things that lots of you will have might remember participating in about a year ago was a study that we did called Getting Results, where we asked you what your preferences were around getting your scan results, essentially, so how that is communicated to you. And it was things like if you wanted a printed report, if you wanted to see pictures on the doctor's screen, lots of that kind of feedback. And we actually wrote it up to present, with the hope of presenting it at the European Neuroendocrine Tumor Society conference, which is like the worldwide bee's knees of neuroendocrine cancer conferences, and it happens every year. And we're really delighted that actually that was accepted, and it's accepted as a poster presentation, which means that we write those results up as a poster, which will be presented. It's a virtual conference this year because of silly old COVID, so we'll be presenting that. And we also have the opportunity to record a video for a couple of minutes on that research. So I'm actually really excited about that. It's wonderful to get recognition of a consumer-led research project in a scientific conference. So that's actually quite a lot of kudos for our consumer advisory group, and particularly the people who worked on that project. And I'm looking forward to being able to share that poster with you when we've got that together. We're just in the process. I only found out about it yesterday, so we've got a bit of work to do to get all of that ready. So probably after the conference, we'll be able to share that poster with you all. The other thing, just to let you know, is that next week we've got a couple of groups on. So the group that normally meets at the SAN Hospital, they've got an online meeting next week via Zoom. So as you know, probably those of you who have been linked in with our geographical face-to-face support groups or needed to go onto Zoom last year because of COVID, we're looking forward to when the community immunity looks better and we'll be able to meet face-to-face once again. But at the moment, Zoom is still the way that we're going, and the SAN group's kicking that off next week on Thursday, I think. And also, having second thoughts, it is Thursday. I'm sure it's Thursday. Next week also, we've got the first meeting of our online Zoom group. So this is a group that is for people who are in our Facebook private discussion group to get together Brady Bunch style via Zoom, and especially for people who live in rural areas. I think that's a really useful thing to be able to do, so we can hear each other's voices and we can see each other's faces. We know it's not the same as being in the same room as each other, but it's often really fantastic, and the conversations we have in that group are always come away moved and amazed and challenged and fascinated, and always I learn things about people and their tumours. So the event listing for that is next week. Beg your pardon, the event listing for that is in our Facebook private discussion group. So keep a lookout for that. I just posted that up just a little while ago. So look, that's it for me. I hope that you had an okay time over Christmas. I know a few people actually made it into hospital, which was really tough to see. And I'm very appreciative of you all in our Facebook private discussion group for the supportive conversations that I saw when I got back. And a special thanks to our volunteer moderation team who kept the home fires burning and kept everybody, safe and well and kept our groups running over all of our groups. So special thank you to those people. So I will see you next week on Facebook Friday. I look forward to hearing and seeing what the conversations are between now and then. Let me know if there's a topic that you want me to particularly look at, or that we can get a guest speaker on. As I said, the COVID vaccine one is my biggest kind of shining bright priority, but I've got a few others in the mix as well. Yeah, but let me know if there's something that, if there's a question you've got. It's probably not a silly question. It's probably one that some other people have as well. So bring them on. We'll see what we learn together. All right, well, I will sign off there. I hope you all have a good week, and we'll talk soon.